When should pancreatic cystic neoplasms be removed versus watched? Imagine discovering a small cyst in your pancreas during an imaging scan. You might wonder if it needs to come out or if it can just be watched over time. The decision depends on several important factors. First, the type of cyst matters a lot. Some cysts like intraductal papillary mucinous neoplasms or mucinous cystic neoplasms have the potential to turn into pancreatic cancer, so they often need closer evaluation. On the other hand, serous cystadenomas rarely become cancerous and are usually just monitored unless they cause symptoms or grow significantly. Pseudocysts, which are not true neoplasms but often result from pancreatitis, typically don't requiring removal unless they cause discomfort or complications. Size is another key factor. Cysts larger than 3 centimeters, especially if they are IMS, may raise concern. However, recent studies suggest that cysts over 3 centimeters without other worrisome features might be safely observed with regular imaging. Features seen on scans that increase concern include mural nodules, a dilated main pancreatic duct, or thickened cyst walls. If these are present, surgery might be recommended. Symptoms also guide the decision. If the cyst causes pain, pancreatitis, or obstructs parts of the pancreas or bile ducts, removing it is often necessary. But if the cyst is asymptomatic and shows no signs of high risk, doctors usually prefer to monitor it closely. Advances in molecular testing and cytology are helping refine these decisions. For example, analyzing cyst fluid for mutations or suspicious cells can provide clues about cancer risk. While these tests are promising, they are not yet standard everywhere and are used alongside imaging and clinical judgment. When it comes to surveillance, small cysts that look stable over time can often be watched with periodic MRI or ultrasound scans. Some guidelines suggest stopping surveillance after 5 years if the cyst remains unchanged, but others recommend lifelong monitoring because the risk of developing pancreatic cancer can persist. Of course, surgery carries risks, especially with procedures like pancreatic honectomy. The decision to operate balances the risk of missing a cancer against the potential complications of surgery. This is why a team of specialists, including surgeons, radiologists, and gastroenterologists, often collaborates to make the best choice for each patient. In summary, cysts that show high-risk features such as size over 3 centimeters with additional concerning signs, main duct involvement, mural nodules, or suspicious cytology should generally be removed. Smaller, stable cysts without these features, especially if they are branch duct IMS or serous cystadenomas, can often be safely monitored with regular imaging. Always consult with healthcare professionals who can evaluate your specific situation, considering all these factors, to determine the safest and most effective approach for your pancreas health.